People are continuing to come in, and we'll give it just a few more minutes, and I'll wait until it kind of slows down a little bit before we officially start. So welcome everyone who's joining. Obviously you're all on mute as we're starting to kick off the meeting. Once everybody has, or once the volume of people joining has settled down, I will share some logistics with everyone, and then we'll get right underway. Still joining. So we'll give it another 1 or 2 minutes before we get started. For those of you just joining, welcome to the Healthcare Transformation Novelline Speaker Series. Just waiting for others to join. Obviously you're on mute as we await arrival of the other attendees, and you will continue to be on mute throughout the session. It seems the pace of entry has slowed down. There are still a few trickling in, but in the interest of time, to make sure we're able to get through the entire presentation and have time for questions and discussion at the end, I'd like to go ahead and get started. The agenda for today, well, first of all, welcome again to everybody to the Healthcare Transformation Labs Novelline Speaker Series. Very excited to be kicking this off in this new virtual format for everybody. With all the things going on, this is a new experience for everyone. So very happy to have everybody join. Just some logistics for this meeting. Everybody will remain on mute during the session, and I encourage everyone, if you have questions or when you do have questions, to enter them using the Q&A function as opposed to the chat function. We will be moderating those questions as they come in and allowing, oh, we've got the view of the key.
Yeah. Oh, no, I was just
so we will be going over the questions and answers at the end of the session. But to get us started, my name is Paula McCree, and I'm the Managing Director for the Healthcare Transformation Lab. And we will first hear some words from Eric Isselbacher talking a little bit about the Novelline speaker series, and then Jared Conley will introduce himself as well as speak a little bit about the context and his understanding and do the introduction of our featured speaker today, Dr. Arnold Milstein. We'll have about a 30-40 minute presentation, and then we'll have 10-15 minutes for questions at the end of the session. So welcome everybody again, and I will now turn the presentation over to Dr. Eric Isselbacher.
Great, thank you, Paula, and thank you all for joining us today. My name is Eric Isselbacher, and I'm the director of the Healthcare Transformation Lab here at MGH. And on behalf of the entire HTL team, I'd like to welcome you to the Novelline Speaker Series. This is a series of quarterly talks, which was launched thanks to a generous gift from the Novelline family, friends of the lab and friends of the hospital, to which we invite speakers from a variety of backgrounds, both from academia and industry, to share with members of the MGH community the lessons and insights about the process of healthcare innovation and transformation. We're very pleased today to have Dr. Arnie Milstein from Stanford join us as our speaker. And to introduce Dr. Milstein, I'd like to turn the microphone over to my colleague, Dr. Jared Conley, who's the Associate Director of the Healthcare Transformation Lab. Jared?
Yeah, thanks, Eric. Good afternoon, everyone. Great to be with you all. Excited to hear this continued speaker series today. I have the great privilege to introduce an individual who's been incessantly seeking to improve U.S. healthcare ever since he left Cambridge many decades ago. Arnie Milstein is the professor of medicine at Stanford and directs the university's Clinical Excellence Research Center, otherwise known as CERC. The center engages faculty from health, computer, and social sciences in the discovery and replication of innovative healthcare delivery methods that safely lower per capita healthcare spending for excellent care. Before joining Stanford's faculty, he spent a career in applied research spanning both the private and public sector. After creating a healthcare performance improvement firm that he expanded globally following its acquisition by Mercer, he co-founded 3 national influential public health initiatives. The Leapfrog Group, which many of you probably know, is included in that. He was appointed to consecutive term as a congressional MedPAC commissioner, and in that role, he originated 2 subsequently enacted legislative changes to improve the value of healthcare. He was also a founding staff member and serves as the medical director of the Pacific Business Group on Health, the largest employer-led regional healthcare improvement coalition in the US. Citing his national impact on innovation and healthcare policy and delivery methods, he was selected for the highest annual award of both the National Business Group on Health and of the American College of Medical Quality. Elected to the Institute of Medicine of the National Academy of Sciences, he chaired the planning committee of its workshop series on best methods to lower per capita healthcare spending and improve clinical outcomes. He was educated at Harvard, Tufts, and UC Berkeley. On a personal note, I had the great privilege to spend time as a fellow at Arnie's Center almost a decade ago now, there at Stanford, and reflect on that time as some of the most intellectually stimulating and fun time of my career. And I just, it's a great privilege to have Arnie here. And with that, I'll turn it to you, Arnie.
Thank you both. It's a pleasure to be cyber back in Boston again. It's a place that's near and dear to my heart. And I remember doing my pathology rotation there at the MGH, and that my basement memory of the hospital is forever with me. Actually, it's sort of, it's hard to pinpoint, what it is that sort of causes any individual to kind of devote their career to a particular topic. But I think in my case, my interest, throughout my career has been on improving performance more generally. I'm just curious about, how in any industry some organizations perform better, and it was, I think, not unrelated to the fact that when I started nursery school not far from you in Marblehead, where our family lived for a couple of years, I had the unfortunate experience of being pushed a grade ahead, and as a consequence of that, throughout my childhood, I was always a year younger physically and mentally than my peers. And this, particularly if you're a competitive boy who idolizes athletes, can be a major problem. And it was about age 10 that I think an empathic, Little League coach took me aside and said, you know, if you changed your swing in 3 ways, it would make a big difference. And I think what I remember about that was, first of all, the level of abstraction that he used to essentially tell me what changes might improve my performance was easy for me to grasp. There were 3 simple things. And I could mentally sort of immediately grasp what they were. And they indeed made a huge difference. I went from being picked 8th out of 9 typically at the start of any game to being picked 2nd, and I think that sort of locked in my interest in understanding, no matter what I was engaged in understanding how it could be done at a higher level of performance. And that sort of carried me right through college across the river and medical school and my training, and devoted my career to it. How does one go about understanding what it is about differences in how work is done that leads to higher performance? When I came to Stanford and had an opportunity to dedicate my career to research and training, and the pleasure of training talent like Dr. Conley, it occurred to me that, you know, the news reports on, you know, I don't know if some of you, if you can Google this, might want to Google diseases of despair. But one of the things that's happened, and I use this picture to kind of characterize it, is over the last couple, maybe 20, 30 years, is the first time in which the American dream of your kids being better off than you economically and educationally began to deteriorate. And as you're probably many of you are aware, many American workers and families that aspire to decent housing and a comfortable life and a little bit of economic margin find themselves in the situation of this young family. Their dreams hopefully are still alive, but as you can intuit from the background, things aren't going well for them particularly. And so that problem is something I've devoted the last really 30 years of my career to try to do something about. And borrowing from the kind of the difference in my life that the Little League batting coach made, I began to get interested in what's different about American patient-facing clinical teams that leads to lower per capita spending, or for episodic care, like let's say an elective procedure, lower total spending per episode of care, and better, if not either equal or better, clinical outcomes and patient experience. And as you can see, for those of you who didn't have a chance to read the pre-read, I've provided a link in this cover slide. And I encourage you to read it, because it's a story about Boston. It's a story about your hospital and other hospitals in Boston. And it's, I think I don't want to give away, if you haven't had a chance to read it, give away the story. It's easy, it's a quick read. And I think it's something that may stick with you and perhaps influence, you know, the direction in which you take your careers. So let's take a step back and sort of what was the nature of the problem that, you know, that really drew my attention and caused me to apply my curiosity about improving performance to. So Paula, let's go to the next slide. So Warren Buffett, you know, famously analogized American healthcare spending growth in excess of national income, or GDP growth, as a tapeworm that was, let's see, something has happened to my screen. I'm not sure. Here we go. He's analogized that gap between annual percentage growth in healthcare spending and annual characterization of America's income, which is what GDP is, as that difference being ongoing and chronic is he analogizes it to a tapeworm slowly bleeding out American prosperity and the American dream, and the ability to do so many things, including better fund K through 12 education, and and have more resources for things that make a difference, like international security, regardless of what your preferences are for, for having more for either low-income workers to spend or for public institutions like school systems to spend. It's if you have any one sector like the healthcare sector outgrowing national income every year, it begins to suppress your ability to spend on other things. And that family's picture in the upper left, what they, as a result of healthcare spending growth being in excess of average national income growth, what they have less of is to buy decent clothes and to live in decent housing. We'll come back to that. But those people are the kind of people that are being crushed in this tapeworm's jaws. By the way, the tapeworm was those red lines were something that just occurred to me one day, and I realized that that's how to make the connection between this fundamental relationship and what Warren Buffett was talking about. So, what is the equivalent? How do we go about figuring out, what is the equivalent of what that little league coach taught me? That if we were to enable that information to get in the hands of clinicians who care about this problem, could begin to close this tapeworm's jaws, if not more than offset the gap. Paul, let's go to the next slide. So obviously in any industry, there are some that are performing better than others. No one had ever tried to do this at the level of patient-facing clinical teams. And the reason is that for so many years, it was impossible for any researchers to get a hold of a really big national health insurance claims database and begin to, that included the identity of individual physicians or of individual physician practice locations, and begin to calculate two dimensions of performance, which are shown on this graph. The first, which is a vertical axis, is for the quality measures that have been sort of nationally blessed by the National Quality Forum and Medicare. It's possible to pull those together into a composite score if one uses a clinical panel to weight their relative importance in population health. And the vertical axis was something I borrowed from an effort that I had helped initiate in California, which is essentially an ability to calculate for California's 225 organized medical groups that take some risk for health insurance spending per capita. The risk adjusted and geography adjusted total cost of care, that's what TCOC is, for privately insured California is expressed as a per member per year. And that's back in 2016. Obviously, it's much higher now. But once you do this, regardless of whether you do it on a state level, at the level of physician organizations, or whether you drill down to patient-facing clinical teams practicing in the same location and do it on a national basis, you begin to see this distribution. And my intuition was that what was going on in that first outer left-hand circle, I could characterize as today's positive value outliers. It's basically high quality composite, low per monthly total healthcare spending on a risk-adjusted basis for the patients whom they take care of. And then that circle, that oval I drew to the far left, is what I hope some of you, since you have long career runs ahead of you, where you will take your practice, the delivery system, if you end up in a position higher up in an organization, where I hope the kinds of ideas that perhaps you're already dreaming about might take you and enable you to be operating an American bright spot with respect to value of patient-facing clinical care. Let's move on to the next slide. So I said, I refused to give up easily in most things. And though no one had done it before, I finally figured out how I could get a hold of a big national health insurance claims database that would denominate it at the level of patient-facing clinical teams, and which had the identities of the patient-facing clinical teams known. That enabled me to, characterize their per capita spending, really for any type of patient-facing clinical team. This shows you the areas in which we've initially published our findings from these bright spot care research explorations have been for primary care for two populations. One is the high risk, high cost population, primarily elderly, and the other is for a general privately insured American Blue Cross Blue Shield national population. We've also done something similar for nephrology care, oncology care, and we have a number of manuscripts, in preparation that examine other categories of patient-facing clinical teams. What we do once we identify these high performers is we then use a combination of on-site review by clinicians who are blinded with respect to whether or not they are looking at bright spot teams or teams we draw from the middle of the distribution, and as well as sort of broader surveys of high performers and performers all across the spectrum. And we use that to kind of tease out tangible, potentially transferable ways of delivering care that appear to be statistically associated with lower per capita spending and higher quality. Those obviously become hypotheses because, since correlation is not the same as causality, it isn't until you try some transplant experiments to know whether or not these ideas actually, whether what you've picked up is pure statistical noise, or whether what you've picked up is something that when transferred, indeed, to use the metaphor I was talking about earlier, begins to move your batting average from, mine was probably 150 before that coach coached me up into a respectable, a distinguished range. If you sort of look across all four of these national bright spot studies, you begin to see certain broad themes analogous to the 3 tips that batting coach gave me, that regardless of specialty type recur. The first is the theme of targeting, and a clear example of that is most of these teams begin to sort of, as they're looking at a patient, begin to ask the following question about the future. They say, based on what we can see about this patient's history and their behavioral propensities and the nature of the specialist community around them, what are the most likely ways that they are likely either to experience a preventable, serious, expensive health crisis, or be dragged down a specialist, call it an exploratory pathway that excites a specialist, but which a well-informed patient in terms of likely benefits and risk would in no way want. So that's what anticipatory health crisis prevention means. Some of the teams doing this are using tools like the Patient Activation Measure, PAM. It's a simple survey-based scoring system that gives you, particularly if you're managing a longitudinal care, as these three specialties are, a clue about whether or not whatever you tell the patient to do between visits is actually likely to get done. Having a quantitative measure of that, you can just intuit how useful that would be in deciding whether or not you should assign a medical assistant to support that patient between visits. But that's what anticipatory health crisis prevention, that's an illustration of that. Tailor means, once you've decided what the major risks are, coming up with an intervention that is kind of designed to address whatever you think are the primary risks that might lead to a patient entering a period of potentially preventable crisis, or I'll call it overly optimistic specialist workup. The term that I published for this, it was care traffic control. This is something I published in one of the references I'll share with you in a minute, in a Health Affairs article about 10 years ago. And then last but not least is this notion of TRIM. That is if one ends up implementing really successful ideas in categories 1 and 2, target and tailor, but one doesn't pay careful attention to the new intervention being staffed and resourced with the least expensive resources, you can re-experience what America experienced between 2000 and 2010, when it launched almost 100 experiments in Medicare population, in intended higher value approaches to care innovation for the Medicare population. And only one of the 90 plus actually saved money. And if you look through the sort of the rubble of that unfortunate, national experiment, most of the interventions actually did lower ED use and lower hospitalization. But because most of them didn't pay attention to the cost of the intervention, the savings were more than offset by the cost of the intervention. Okay, let's move to the next slide, Paula. Okay, and then just to drill down a little bit more, because I just showed you the very high level, the results that through four different specialties shared. Here's what we found in that specifically with respect to target, tailor, and trim, when we looked at what was different about primary care practices that were national bright spots in the value of the care they provided for privately insured Americans. And what we saw here was risk-tailored patient care plans. Obviously, it's a reference, it's an illustration of target. For primary care patients, we also saw something interesting, which was collaboratively insourcing the simplest 20% of commonly used specialty activity. Typically what happens in these primary care practices is a primary care physician with a particular interest in orthopedics would decide they were going to do the 20% simplest part of orthopedics in the practice, rather than referring it out. It was a lot less expensive. It's a lot more convenient for the patients. And so what they do that is they would reach out to whoever was their go-to orthopedic practice group, explain they wanted to do this, commit to continuing to refer their patients who needed the 20% more complex end of orthopedics to that specialty group, but in exchange ask for that orthopedics group to provide telephonic support and advice to whichever of the primary care physicians decided to take responsibility for the simpler part of orthopedics, like injecting cortisone into joints when appropriate. And then last but not least, cognitive simplification to support team care. These practices delegated a lot to medical assistants, but the only way to do that is through standardized practice protocols and practice methods, and a fair amount of, even back then when this was done, making better use of the electronic health record. The high performers, as we published this in Annals of Family Medicine, the high performers relative to those selected from the middle of the distribution on cost and quality had on average generated a 14% higher quality composite score and 34% less annual total per capita spending for healthcare for the patients for whom they served as primary care physicians. And as I mentioned, transferability testing is ongoing, but in a minute, I'll share with you some of the early transferability results. And as you'll see, they are quite positive, suggesting that what we're detecting here is signal and not noise. Paula, let's move on to the next slide. So here's just for those of you who have trouble sleeping at night, I just, via these links, which we'll send out to you a version of these slides that you can click on the links and get the references. But here's this and the slide that followed just provides some of the findings from some of our bright spot studies. This is a list, interestingly, of there's a number of ways you can do bright spot studies. Before we were able to get a hold of this national health insurance claims database, we simply mined the published literature, and this was part of Jared's experience when Dr. Conley's experience when he was one of our research fellows. He and his team were given a year to mine the literature on stroke care and come up with an evidence-based approach to making no more than 3 changes that would, for patients at high risk of stroke, lower national per capita spending and improve clinical outcomes. And so you will see either on this page or the page that follows the article in the clinical journal Stroke that Dr. Conley and his team published. And there were 3 ideas, and they essentially engaged in a national treasure hunt through the published literature, and then talked to some of the researchers who were studying this to get their ideas as to what was actually happening at the innovation frontier, and then distilled 3 ideas, simple for any hospital team to understand. It involved changes in primary care, emergency department care, and stroke neurologist care. But that's now, some of those ideas have been tested with success in other delivery systems. Let's move on to the next slide. So what about early transferability testing? I mentioned that it's going pretty well. Well, one of the first teams we launched tried to come up with no more than 3 ideas that would lower per capita spending for patients with poor prognosis cancers. And one of the ideas they came up with, which I'm calling high value oncology care attribute number 1, one of the 3 things that the team came up with, was the following relatively simple idea. And it was, if patients have a poor prognosis cancer but are not at the end of life, since oncologists are pretty busy and in the opinion of our design team, tend to be optimistically biased about, I think Atul Gawande referred to his own failure in sometimes leveling with his oncology patients as him inadvertently finding himself to be a merchant of hope. Great turn of phrase. But the theory of what our team extracted from the literature was that if one had a neutral party who wasn't as busy as an oncologist, under oncologist supervision, to kind of sit down with the patient and their family, be clear with them about what the probability was and their likely experience would be of different outcomes under the different treatment options available to them, ranging from comfort care to curative care. The bet was that a lot fewer patients would opt for aggressive care than would occur when oncologists had the same kind of counseling sessions with patients. And intriguingly, I think one of the pieces of research that the team looked at in that influenced this particular design of this particular attribute, was research, I think, done at MGH, which showed that patients with poor prognosis brain tumors, when shown, I think they were shown videos of cardiopulmonary resuscitation for patients in the ICUs. The percentage of patients that wanted to go ahead with curative treatment for this poor prognosis brain cancer was near 0. But anyway, that was illustrative of the kind of literature that then caused our team to think that this might make a difference. And an RCT was launched by our fellow in conjunction with one of the California VAs, and published in JAMA Oncology. And as you can see, the savings, the reduction in spending was actually larger than was hypothesized based on their JAMA, the paper that they published that articulated these three ideas on lowering the cost of better care and better patient and family experience, and more patient values concordant care via this method. Another test we'd had was, I won't go into detail, but I mentioned there were three care attributes that were extracted by our oncology team, but another one was tested in a large community health system in Southern California, not the VA. A different aspect of the model, but pretty much aligned with as predicted by the Bright Spots researchers. It resulted in a 7% net reduction, and this was actually I'm referring actually to the third bullet here. Sorry, a 30% net reduction. The second bullet refers to an interesting effort at scale. This is with medical groups and primary care practices in California, caring for hundreds of thousands of patients. CMS sponsored a test of the ability to distribute these three ideas on how to better manage high need, high cost patients covered by Medicare. And CMS brought in an independent actuary to analyze whether or not per capita spending went down and measures of quality went up. And the M&R, which is a large national actuarial firm, concluded that relative to what was a plausible counterfactual, net spending went down by 7%. So let's come back to sort of why this work is important, and that's that that picture in the bottom right hand corner. And for those of you who don't have the time to follow up on the pre-read we sent before this, it essentially what that story told is it was an LA Times story about Boston hotel workers. And these are people, paid, they belong to a union, they're paid on an hourly basis. And their predicament about roughly maybe 10 years ago was that because the nature of their contract, the workers' contract with the hotels was such that it was kind of think of it as sort of a blanket wage increase contract over multiple years, and every dollar that was not absorbed by a rise in health insurance spending then became a wage increase for these hourly hotel workers. But because their premiums had gone up much more quickly than the permitted 2 or 3% increase in compensation. I don't remember what the base agreement was, but they had not had a raise in three years. These are people who were living roughly on $14 an hour in urban Boston, and leave it to your imagination as to what life, particularly if you have a family and kids, what life like that might be. And so out of desperation, the union leader went to his insurance plan and said, "My people have not had a raise in 3 years. What can we do? I'm desperate." And they said, "Well, you have the network that supports your insurance plan includes all of the hospitals and all doctors in Boston, and there are some very big differences in the average cost per hospitalization and hospital outpatient procedure between some of the hospitals in Boston." And the insurance company said, for example, the Brigham and Women's Hospital is a Harvard teaching hospital. What they charge us for the typical procedure is about a double what one of their neighbor, hospitals, also part of the Harvard Medical School system, Beth Israel Deaconess charges. And so if you're willing to remove the partners hospitals, from your network, it could allow a big reduction in how much you have to pay on health insurance costs, and that would enable the big wage increase that you'd like to give your $14 an hour coworkers. And the union leader, my guess is, his blood pressure went up by at least 30 points at that point, because he realized that a fair number of his members have chronic illnesses and were, deeply connected emotionally to partners, physicians and partners hospitals. And this could be a recipe for a union leader not being reelected. And so what he did is he basically said, I don't know what to do. I'm going to put it to a vote, because this is not only for me to decide. And so it was put to a vote, and the union members voted 2/3 and voted to eliminate partners hospitals from their network. And 1/3 voted against it. And my intuition tells me that 1/3 was the very people who loved their partners' physicians and the care that they got. But when they looked at the available, quality comparisons, the union membership and leadership decided to go forward with it. And the article the link I sent you describes what happened to one working class Boston family. She's a hotel maid. She's the one who cleans up the rooms, and what happened to them is that they all of a sudden got a 20% raise. And if you're living on $14 an hour, that is a material difference. And then they got subsequent raises in the 2 or 3 years that followed, because the increases in price in their health insurance plan was not only on a one-time basis did they have much lower costs for hospitalization, but they also on a going forward basis had lower rates of increase. And the story ends, that's not a picture of them in the bottom right, but there is in the Globe story, in the Boston Globe story, a picture of them. And they were able to, for the first time, move out of a rental apartment. Her comment was, try living in a 2-bedroom apartment with 3 kids, which is where they were living. They were finally able to buy a duplex in East Boston. And I think I won't give away kind of the closing paragraphs of the article, but I hope you'll have a chance to read it, because it's something that, regardless of what direction you take your careers, I think you will find deeply affecting. And it'll also help you see the relationship between anything you do in your subsequent career to aid and abet the discovery of lower cost ways of delivering great care, the impact it can have on people who are, who didn't have the educational advantages and intellectual gifts that all of you are blessed with, and who are hoping to revive the experience of the American dream for their kids. Jared and Eric, I hope you've been monitoring the questions that have come up and are coming up. And Jared, maybe you could ask me, bring up either some of the comments or some of the questions that you think might intrigue the most people who have joined us this morning.
Yeah, great. Thanks, Arnie. Appreciate that. I think it reminds me actually of Professor Daines there at Stanford as well, gave a recent address at the commencement of the Stanford Law School. He referred to the Latin root of the word tolerance, and it's to bear pain and hardship. And he ends the commencement address by saying, our lives are defined by the pains we volunteer to bear. And I think the work that you've outlined is exactly that, right? That we, as part of our reaching inside and understanding, why we're about the mission that we do, that we are about, bearing those burdens of others, and, why that might have been thought of as just the medical burden. It's hard to do that without thinking about the cost burden. So I appreciate all that you've done to highlight that, both locally and nationally, and internationally for that matter. I think one of the questions that has come up as we've reflected on some of the work you've done, you've obviously spent a lot of time, rethinking healthcare, Was curious, you outlined a few different ways that physician and clinician innovators can think through better ways of reimagining care. Curious if you could highlight a few other effective methods to innovate in the service delivery space. I know as fellows, you highlighted some of the literature review we did. Maybe you could speak a little bit more about what you guys have found regarding design thinking, needs assessment, et cetera.
Sure. Well, and also before I say that, I also want to say that that had this story unfolded, out here in Northern California, I doubt that Stanford Hospital would have fared any better than Mass General and the Brigham and the Partners Hospital. So just to be clear that this is a problem that we all face, and we can all make some progress in relieving. So how do you do this type of work? Well, I mentioned one of the most important tools, which is, for the first time in America now, we can access big health insurance databases. The disadvantage of those databases is the quality composites that you can put together based on health insurance claims databases are nowhere near as good as the quality composites you could put together if those health insurance databases were linked to electronic health records. So one of the most important opportunities, I think, coming up during the course of the careers of the people who have joined us this morning is, my guess is, within the next 5 years, any of you will be able, who are curious about understanding what's different about your peers, and have it's an opportunity for you to collaborate with people who've got the health services research skills to begin to first of all probably make better rank peer clinical teams around the country, and secondly learn from them. I mean, the data sets are getting much richer for doing this kind of work, and so that's one tool that is very important in terms of being more confident that what you've identified is true, better clinical performance, rather than performance that appears to be better, but based on poverty of quality measures in a particular specialty may be a false, may represent a false signal. Second thing that Dr. Conley mentioned, this probably is worth talking about, is the opportunity when you're trying to formulate a better, less expensive way of delivering care, of spending a little bit more time than you would otherwise intuit would be necessary, kind of understanding the most strongly felt unmet needs of clinicians, of patients, and their families. The general term for that is design thinking. You've probably heard of that, but it's a way of looking more deeply and not just asking people what they would like to happen differently, but using a particular technique that is widely published if you Google human-centered design and design thinking, to really understand the most deeply felt unmet needs that underlie whatever it is people in a clinical environment, whether they're patients or clinicians, find dissatisfying. Because if you can understand that, and you can sort of merge less expensive, better ways of delivering care with an innovation design that also addresses people's most deeply felt unmet needs, they are much more likely to be adopted. And just a more tangible example of this is, Henry Ford said, if I just would have listened to Americans, around the turn of at the beginning of the 20th century, around 1900, I would have tried to design a faster horse. But that's really not what they wanted. If you understand their needs better, their most deeply felt unmet needs, it had nothing to do with. They thought they wanted a faster horse, but actually there was a better way. But understanding the needs that underlie what it is people say that how they'd like healthcare to change, helps enrich the ideas that you can then consider in coming up with a kind of an amalgam of kind of cost lowering techniques with ways of delivering care that are more patient satisfying.
Great, thank you. I think you spoke a little bit earlier about the idea of cognitive simplification. And I'm just curious, you've obviously done a lot of work in a kind of parallel space in what you refer to as ambient intelligence, in this idea of using AI to help clinical teams reach a higher value care. Could you speak more to that, to those realities that you've discovered over the last few years?
Sure. So, for those of you who are not familiar with somebody who's, now long since, was once someone who, one of the earliest people in the United States to sort of point out that the rate at which outcomes research was being published on, this works better for this population, this works better for this population, had actually overrun all ability, of humans to kind of grasp it and integrate it, into what they did, and as a result, it's just beyond, human cognitive processing to kind of keep track of it and sort of integrate it on a regular basis into clinical decisions. And what Jared referred to is a basic research article that I co-wrote in the journal Nature and was published last week on what we refer to ambient intelligence, because the second problem of the growing complexity of modern healthcare, it goes beyond ordering a treatment, but it has to do with the complexity of perfectly delivering a treatment. I think one of my colleagues at Hopkins actually counted how many physical action steps per NICU baby per day was expected of frontline clinicians in the NICU at Hopkins, and they stopped counting at 600. So, my view is that one of the tools that any innovation design will have to begin imagining as we begin to better refine and tame these electronic health records, which are currently the bane of most of our existences. But eventually, these tools will pay off. But one of the things that I believe better quality, lower cost practice will eventually be associated with is a form of we in our article in Nature refer to continuous ambient intelligence. It's basically taking in information from multiple sources, including sensors on or about the patient, and information from the electronic health record, and sort of continuously attempting to infer a next best action. And then when next best action is identified via computation, if it reaches a certain level of incremental gain, alerting the patient-facing clinical team that there is a next best action to consider, and here is if you're interested, you can click on some of the references and relevant information that that suggests this is a better treatment option. And obviously, you don't need to click on anything if what the ambient intelligence has detected is an exhausted physician or nurse inadvertently entering an ICU room without having used the hand hygiene dispenser.
Jared, you're muted there.
Thank you. Thanks, Arnie. A couple other questions that have come in. Someone says, I feel like we focus a lot on high value care in the primary care space, and understanding value-based care is part of primary care training, health policy training that mostly general medicine docs pursue. Two of your findings were about oncology care. How do we communicate with that population of physicians and ensure they understand high value care?
Sure. I mean, I would say, if you're being trained at Mass General, there's a very high probability that you're going to be a clinician leader in the United States over the next 5 to 15 years, if you wish to be, and and so gifted young physicians like yourselves are going to be in a position to devote their effort to kind of what researchers who are working on this problem, what they are uncovering about better, less expensive care, and communicating that to your peers. There's for example, in the two areas, in almost all, actually at this point, there's probably no medical specialty in which at this point there aren't some leaders around the country who are curious about and beginning to kind of uncover better, less expensive ways of delivering care. If for any specialty in which that's not evident, what our fellows have found is simply by calling well-managed healthcare delivery organizations that are globally capitated and hold themselves responsible for quality of care performance, like for example the Permanente Medical Group, regardless of whether it's in California, Oregon, Maryland, or Georgia. But usually getting on the phone to colleagues like that and sort of say, you've been part of a system that's been accountable for total per capita spending and high performance on publicly disclosed quality scores, for a period of time. How do you deliver XYZ, specialty care? And then getting interested in what's different about that approach to delivering care in a given specialty relative to how it's currently being done in your institution. That we often, our fellows get some of their best ideas by networking to Permanente Medical Group or Health Partners in Minnesota or any other sort of well-respected, globally capitated delivery systems that have high performance on publicly reported quality scores. So that's another resource if in your particular specialty, Bright Spots research is not being published.
Great, thank you. Curious if you have any, there's a question here about, claims and billing data having pros and cons. With more EHRs being dispersed around the country, is there a way to link claims and clinical data at larger scale for more richer information to make some of these insights? Yes,
absolutely. Some of the big national purveyors of health data, and I'll mention one that I have absolutely no economic affiliation with, and I should have actually, I apologize at the beginning, disclosed that nothing in the content of my talk today relates to any private company from which I derive economic benefit. But companies like Optum, which is a division of United Healthcare in Minneapolis, are already beginning to sell data sets that link health insurance claims data with electronic health record data. Unfortunately, at this point, they tend to be disappointingly small data sets, typically relating to maybe populations of 1 million Americans with an average duration of information of maybe a year and a half. It's not really, doesn't yet lend itself to some of the intriguing opportunities to essentially use that to begin to sort of pursue the National Academy's vision of where healthcare will go, which is a continuous learning system that then feeds something pretty close to ambient intelligence.
Great, thanks, Arnie. I think for time, we'll have to close the questions there. I'll turn over to you, Paula.
Well, thank you, everybody. We are at time. Thank you very much, Arnie, for your very insightful words and interesting commentary. All the participants as well. Clear we had a number of people in some conference rooms, so it's great to see the volume of people participating. We will be posting a recording of the session on our website, and I will have the PowerPoint presentation in PDF format available for those references as well. Any closing comments or words, Eric, Jared, or Arnie?
Well, Arnie, thank you on behalf of the lab and of MGH. We'll have to get you back in person sometime in the future so that you can meet people, talk a little bit more in person about you know, some of the bigger issues that we still have to face, like the culture change in order to make some of these things happen. But it's very provocative to see the potential for these bright spots. So thanks very much for joining us today. And thank you all for attending.
Likewise. Thank you, Eric.